Hello everyone, my name is Richa. The aim of this assignment is to do a focused cardiovascular assessment and management on a patient in a cardiac ward setting. Let's begin with gathering of subjective data. Some of the points to be noted are highlighted in blue. We have a 64-year-old male who came to ED by ambulance with chest pain and worsening lower limb edema. The origin of pain was at home while he was watching television. Pain was crushing in nature, radiating to the left arm. He had 3 GTN sprays at home which did not resolve the pain, and he called an ambulance for help. Pain finally resolved after a few more GTN sprays and IV morphine. His cardiovascular related past medical history is ischemic heart disease, coronary artery bypass graft in 2008, atrial fibrillation, hypertension, and peripheral vascular disease. Other histories are type 2 diabetes, stage 3 chronic kidney disease, gout. He does not have any significant family history. He lives alone independently without any services. He's retired, an ex-smoker. He has issues with ethanol abuse. He quit drinking 4 months ago. He has poor exercise tolerance secondary to exertional dyspnea and edema in legs. He states his diet mainly includes frozen and takeaway meals. He states he does not have any kind of social or financial stress. Detailed information on chest pain was gathered using PQRST pain tool, which was recommended by multiple articles as referenced on the slide. These are the list of his current medications. Things to note is that his furosemide was seized by GP as he was having some syncope episodes in community. Interpretation of subjective data. I'm only discussing modifiable risk factors of cardiovascular disease in this slide. According to the study done by Hubeck et al. In 2017, smoking histories and diabetes are the 2 main risk factors associated with acute coronary syndrome. Obesity is more prevalent risk factor in patients below the age of 40. Chronic kidney disease causing increase in cardiovascular morbidity and mortality has come to the forefront of public health now. Other risk factor includes hypertension, dyslipidemia, poor exercise tolerance, and unhealthy diet. Latest blood test results are as per the table. I've highlighted the D range values. Troponin was elevated during ED presentation. However, the second level shows a trend down. D-range urea, creatinine, and GFR is due to his stage 4 kidney disease. HbA1c results depicts uncontrolled diabetes in community. Current studies like the one done by Hubeck et al. Talks about apolipoprotein B to be a better predictor of a coronary artery disease versus low density lipids and triglycerides. ECG shows sinus rhythm with right bundle branch block. Chest X-ray shows no changes. Echo shows aortic regurgitation with left ventricular ejection fraction of 55%, which does not show any changes when compared with previous echo results. Here is interpretation of investigative data as discussed earlier. Since the patient have chronic kidney disease, troponin level is a limited indicator of the heart attack. This is due to the fact that troponin level are always elevated in patients with chronic kidney disease. There are multiple theories regarding mechanism of elevated troponin level, for example, chronic structural changes, reduced clearance, etc., but we still don't have any conclusions from the studies. Echo shows aortic regurgitation with left ventricular ejection fraction of 55%, which does not show any changes with previous echo results. However, the presenting symptoms of syncope, lower limb edema, and dyspnea points towards left-sided heart failure with preserved ejection fraction. Objective assessment. Guidance for assessment taken from Estes, Collegia, Theobald, Harvey, 2016. Reflection on subjective data will assist in gaining objective data. For me, the thing that stood out was syncope episode, his chronic kidney disease, heart disease, and lower limb edema. Vital signs are as per the slide. Patient was experiencing syncope in episode, which could be secondary to orthostatic hypertension. To diagnose orthostatic hypertension, we require a drop of at least 20/10 systolic diastolic pressure, which I could not see during the assessment. The GP in community thought syncope could be medication related and seized his furosemide, which may have led to fluid overload. Starting with inspection and going towards palpation and auscultation, please note percussion have limited usefulness in cardiovascular assessment as X-ray and other diagnostic tests provide the same information and is more reliable, hence is often omitted in cardiovascular assessment. Cardiac assessment of the patient shows no abnormalities. The things that stood out in vascular assessment is highlighted, that is, bilateral putting edema up till knee level, which point towards fluid overload, capillary refills of less than 4 seconds, which may indicate impaired blood flow, which could be due to shock, heart failure, and his history of peripheral vascular disease. Less hair distribution again shows impaired blood flow. Cardiac palpation showed normal results. Absence of pulse may indicate vessel constriction or obstruction. Popliteal and posterior tibial showed thready and weak pulse during assessment, which could be secondary to peripheral vascular disease. Auscultation of heart showed early diastolic murmur, more pronounced in pulmonic, mid-precordial and tricuspid area, which signifies aortic regurgitation, which complements our echo finding. Vascular auscultation showed no concern. Ankle brachial index is not a good investigative tool for seeing progression of peripheral vascular disease, as diabetes and kidney disease leads to rigid blood vessels, making it unreliable. After analysis of data, our main concern are as follows: chronic history of chest pain, fluid overload, syncope episode which makes him a false risk, obesity secondary to poor nutrition choices, ethanol abuse, poor exercise tolerance, pain management of lower limbs, and tight diabetic control. I have split our health priorities into hospital and community-based priorities. I will discuss intervention of these priorities in upcoming slides. While the patient is in hospital, we should manage and investigate chest pain and rule out any acute causes. Looking at patient's investigative result, chest pain seems most likely secondary to fluid overload. Therefore, managing fluid overload is a must. Intervention. We should make chest pain management plan as the concern is chronic for the patient. Education regarding chest pain management that is recommended by Heart Foundation should be given. Resources like My Heart, My Life, which is recommended by Heart Foundation, is helpful for making patient understand their symptoms and management. The other health priority we have is managing fluid overload. While the patient is in hospital, recommencement of diuretics like furosemide will assist in patient with reduction of congestive symptoms. Fluid restriction should be enforced post-consultation with medical team. Education regarding low-salt diet will prevent fluid accumulation in body. Patient reports that he's above 12 kilos from his normal weight. Therefore, daily monitoring of weight will measure the progress of diuretic therapy. Patients should also be educated on monitoring weight at least weekly basis in community for early detection of fluid overload. Syncope episode. These episodes need to be further investigated. There are multiple causes of syncope, whether it's vasovagal episodes or cardiac related. Review of medication, especially after recommencement of furosemide, is required. Postural hypertension should be checked while patient is in hospital. Things like SOS smartwatch should be given to the patient which have inbuilt falls detection mechanism to prevent fall at home. Patient should be educated to wait few moments before standing from lying or sitting position, especially if dizziness is experienced. Cardiac rehabilitation and exercise program. Cardiac rehabilitation is internationally recommended to give patients and family more support during the recovery phase. It can be community-based or home-based to suit the needs of patient. It can be community-based or home-based to suit the need of patients. Diabetic control. Patient's HbA1c was 9%, which depicts uncontrolled diabetes. Involving an endocrine team for medication titration will assist in making tight glycemic control, as diabetes is a risk factor of cardiac issues. Encouraging patients to be accountable for documenting and measuring their blood glucose level will assist in compliance. Nutrition, weight management. As salt makes body hold more fluid, it is important to stick to reduced salt diet. Patients did mention that he takes a lot of frozen meal, which are packed with hidden sodium. Education regarding a healthy fresh food diet is important. Linking the patient with a dietitian and making a safe obesity management plan will help patient manage his diabetes better and decrease risk of further episode. Pain relief. Providing adequate analgesia to manage lower limb pain will improve participation in exercise. Our last concern is his alcohol dependence. We need to investigate psychosocial reasoning behind alcohol dependence so that patients do not relapse in community. Checking electrolyte and replacing thiamine if required will also benefit patient. Hopefully, after all these interventions, patient health is improved. Thank you very much. Please review the list of my reference.